Hello, everyone. Um, Good morning and welcome to the fifth webinar in our mental health dialogue series, which focuses on how to tackle mental health stigma through new digital technology. My name is Annette Kleiboer and I'm the principal investigator of the Reconnected project and a professor in clinical psychology at the Vrije Universiteit in Amsterdam, and that's in the Netherlands. And I'll be moderating this session today. We talk about stigma, and we probably all know that the mental health stigma is important. However, mental health stigma is also complex and it has many layers, and I hope we can discuss some of these today. When we talk about mental health stigma, what we mean is the negative attitudes, stereotypes, unfair treatment that people with mental health health problems face from society. And these harmful views can make others feel left out, ashamed, or seen as dangerous or not normal. When people believe these negative ideas about themselves, we talk about self-stigma, which is also a problem. This may make people feel embarrassed or afraid to ask for help because they worry others will judge them or think they are weak. Since long, digital tools for mental health, such as online platforms or apps, have been introduced as a way to reduce stigma by offering more privacy, flexibility, and control. And often they include parts on normalization of problems. They allow people to seek support without fear of being seen or judged. But are these tools really living up to these expectations? Do they reach the people who feel most stigmatized? And are there unintended consequences to relying on digital solutions, such as missed opportunities for human connection or isolation? These are some of the questions we will explore together today. And mental health stigma is not a simple problem, and there's not a quick fix. It really requires honest conversations, discussions, and thoughtful strategies. Now, we're happy to have you join us today for this important discussion organized by the 7 EU Horizon Europe projects under the European Commission's call, Boosting Mental Health in Times of Change. These 7 projects, Advance, Smile, Mentbest, Reconnected, Improva, Bootstrap, and ASP-belong, are all powered by the European Health and Digital Executive Agency, HDEA. The Mental Health Dialogue series is a space where researchers, practitioners, policymakers, and end users come together to discuss the latest trends, challenges, and advancements in mental health care. And we've already seen that in the previous sessions. In today's edition, we will explore how digital mental health solutions can challenge stigma among vulnerable populations in Europe. We talk about strategies to reduce stigma, but also about the boundaries of being inclusive. These are key questions that will guide our discussions today. How is stigma relevant to the different projects? What strategies are used to decrease stigma in the projects? And what problems, if any, see the projects with e-inclusion? The webinar format is ideal for these discussions as we will not have formal presentations with PowerPoints. Instead, we will engage in dynamic and interactive discussions. Ask provocative questions will be posed to our esteemed panelists and to you, all the participants. And we encourage really your engagement. You can all contribute and share your insights and inquiries using the chat or Q&A in the Zoom. With that, let me give you a brief overview of our program for today. So in a minute, we will start the webinar with an opening speech by Thanasis Rogdakis. And following that, we will have the lightning talks where each project will explain how they tackle stigma and ensure to increase inclusiveness. This will be followed by a moderated discussion during which we will focus on the challenges identified by each project. And we will then open the floor to Q&A session where we will address your questions. So please post them if you have them. Finally, we will conclude with a closing message announcing the series and providing the global registration link for our Mental Health Dialogue series. With that, let's start it. And I'm pleased to invite our first speaker, Thanasis Rogdakis, to deliver the opening speech. Thanasis has a research background in neuroscience and currently works as a project officer for the European Health and Digital Executive Agency, HDEA, that I also just mentioned. Thanasis, the floor is yours.
Thank you, Annette. Good morning, everyone. I'm very happy to open this webinar on behalf of Hadea and welcome you all to the 5th Mental Health Dialogues, part of a collaborative series that brings together our projects funded under the same call. These webinars are a testament to how initiatives supported by the European Commission and Hadea create not only knowledge, but also vibrant communities of practice. These initiatives are about fostering conditions in which your projects can reach one another, exchange lessons, build synergies, and push forward knowledge. You have all seized the opportunity to collaborate, and we fully support your efforts to bridge across projects and disciplines towards shared goals. Today's session touches on a particularly important theme: how digital mental health solutions can help reduce stigma, especially among vulnerable populations. And it is both timely and deeply meaningful. Stigma is often the invisible barrier. It prevents people from seeking help in the first place, encourages shame, isolates communities, and reinforces cycles of disadvantage. For populations already marginalized, whether by socioeconomic conditions, cultural or linguistic barriers, or intersecting vulnerabilities, the burden of stigma is compounded. Your work, designing platforms, apps, tools, and inclusive mental health interventions can help do more than deliver services. It can allow people who have felt the silence to connect, to speak, to find community, and to see that mental health care belongs to them. But this is not easy. Because you're touching lives that are sensitive and fragile, this work must rest on the highest standards of ethics, privacy, and safety. We must anticipate unintended harm, bias, exclusion, or misuse. And therefore, we must build transparency, explainability, and accountability, especially when AI or algorithmic components are involved. We have recently seen in the news the case where the conversational AI was allegedly implicated in the suicide of a teenager. This shows how crucial it is for us to demand transparency, predictability, and explainability from the technologies we develop and deploy. These safeguards are foundational if we are to build trust and truly serve those who need these tools the most. I want to thank each one of you for your dedication and collaboration. By joining forces across project boundaries and across Europe, you're not only advancing the frontier of digital mental health, but also shaping a culture of solidarity, inclusion, and shared responsibility. And your work embodies the core values that underpin mental health awareness efforts. And let me also note, this year's World Mental Health Day, which is around the corner on the 10th of October 2025, is themed Access to Services, Mental Health in Catastrophes and Emergencies. It reminds us that crises, whether humanitarian, environmental, or health-related, exacerbate vulnerabilities and mental health needs, making inclusion and service reach more urgent than ever. In that spirit, the focus of our discussion today is deeply aligned with broader global priorities to ensure that in times of disruption, no one is left behind. I hope today's seminar is rich, challenging, and fruitful. May it spark new ideas, cross-project connections, and strengthen results. I wish you all a very productive session and much success in your collaborations going forward. Thank you.
Thank you, Thanasis, for that really nice introduction. And you're already adding to the discussion. I think it really sets the stage, and it also highlights the importance of our work in mental health with the community scope. So, thanks, Hadea and the EU for funding our projects. Now we'll move on to our lightning talks, and we hear from all the different projects. Each project representative will share their general aim and their target vulnerability groups and elaborate on how they tackle stigma or ensure to increase inclusiveness. Before we start, I encourage all participants again to join the discussion through the Zoom or Q&A tool. And want to first welcome now the representative of Advance and ask if you can introduce yourself briefly, name yourself, your role and the project, and share with us which vulnerable group your project focuses on and how your project tackles stigma or is trying to be inclusive.
Sure. Hi, everyone. I'm Prasansa Subha. I'm currently working as a postdoc researcher in the Advanced project at the University of Copenhagen. So just to give you a brief overview of what Advance is, it is a multi-country initiative across 7 European settings that addresses mental health vulnerabilities across the life course. So it mainly aims to improve our understanding on mental health promotion and prevention. And across different countries, we are working with vulnerable populations, meaning children and adolescents who are currently experiencing climate change related distress, or a population from who are facing social adversity, and also older population in Switzerland. So across different countries, we have like different population that we are currently working with. And with regards to what works in tackling stigma through digital mental health interventions, what we have noticed is the power of language. So the language of the interventions make a huge difference when content is framed around well-being, self-care, and learning, more than around mental health problems, or using psychological word as such. People are more willing to engage. So on the other hand, what doesn't work well is assuming that technology alone will solve a stigma. Stigma is often just the tip of the iceberg for broader structural processes of exclusion. So from an intersectional perspective, mental health stigma can weigh even more heavily on people from minor communities, such as those with lower income or education, which are often framed as social determinants of mental health. So it's not just about individual attitudes, but about wider social forces that tend to value some lives more than the others. So if digital interventions aren't sensitive to these realities, they risk reinforcing the very inequities they aim to address. So in advance, what we are doing is we acknowledge how these various social and contextual factors can play in differential experiences for different people. So we have placed equity at the core of our project, and we are currently using the Progress Plus framework to determine the key equity factors relevant to each country. So in our full definitive trials across countries, we will assess how these equity factors interact with stigma and intervention experience. And we also plan to study different implementation strategies and their role in addressing these inequities. So I can't wait to share more about our findings from our pilot studies in the upcoming, in the webinar over the course. Thank you.
Thank you so much, Prasansa, for your introduction. The next up is Alsbeta from ASP-belong. Maybe you can say something about your project.
Morning. Good morning. Can you hear me? I'm sorry. Yes, that now it looks all right. Good morning, everybody. I'm very, very happy to be here with you today. My name is Ausbeta, and I'm the administrative coordinator of the project we call ASP-belong. I'm a psychologist, and mostly in my work in research, I work with extended realities, virtual realities, and augmented realities, which also applies to ASP-belong, which is a project that takes the technology and tries to find ways to make it as meaningful for the target group of young teenagers. When we think about vulnerable groups, very sadly, we came to the conclusion that that basically all the population of young teenagers, for instance, in the Czech Republic, where I'm based, belongs to the vulnerable group, because in the recent research that was published, I think 2 years ago here in the Czech Republic, over 40% of 9th graders reported symptoms of severe or partially severe depression and anxiety, which is a shocking number. And although we promised and we do focus on socially disadvantaged locations in all 3 countries where we are currently working with the youth, that is the Czech Republic, Portugal, and the United Kingdom, when we actually come to the schools, we see that basically all the young people need the support of any kind, and that's why we're very inclusive in the research that is right now running. So we have around 40 classes of young people aged 12 to 13 in those 3 countries. That makes it 120 classes altogether, and we are working with them through a program that we've designed on mental well-being, psychological well-being. What is important for me, that there are many aspects of the work that we're doing with these young people, but for me, the very basic idea is the stigma that we are working around. We are using a very artsy style of working with children. We're using arts together with the technology to support and enhance the psychological effects that we want to achieve. And what happens is that we are very deliberately avoiding labeling, using the terms that many young people are aware of. They're familiar with what depression is, what anxiety is, but we are deliberately trying to avoid these, working through stories and subjective experience and powerful memories. And this is how we are trying to tackle the stigma among young people. We are right at the beginning of the study, so we will have the result about how we managed in about a year from now. But I wanted to tackle a little bit about the inclusiveness as well, and I'm sure that we will get to that, because we are facing many challenges when we try to use technology to be more inclusive, because technology itself brings a lot of the opposite influence with it. So we're trying to be as open to various needs, be it specific needs in education or the social dynamics of each class that we're working with. I'm sure there'll be space to talk about that a little bit more as we go a little deeper in the discussion. So I would probably wrap it up here and look forward to any other questions and discussion topics that we'll have.
Thank you so much, Asbeta. Then we move on to Nick from Boostrap. Can you introduce yourself?
Good morning, everyone. Thank you for having me here today. My name is Nick Morgan. I'm a mental health youth worker, youth scientist, and CEO and founder of an NGO called Euro Youth Mental Health. We're part of the citizen science work package of the Boostrap project, which focuses on problematic use of the internet amongst young people. Our project, by its very definition, tackles mental health stigma by offering the opportunity for young people to co-create and be part of the designing of the work and the tools and the interventions that we have created. Providing a selection of ways for them to be involved as well, from student ambassadors to young experts by experience, having a variety of roles and methods to be involved. And this in turn ensures inclusive opportunity for vulnerable groups that we are working with, the young people themselves and different young people at different levels of engagement. We work with young people who have lived experience of mental illness, to those with gaps, aged from 12 to 26, or at different levels co-creating, being key decision makers and designers of the work itself, which gives them ownership. And by working in this way, we know that young people are more likely to engage in a 2-1 intervention afterwards if it's being co-created by young people for young people. So that is how we kind of destigmatize, if you will, by helping them be part of that conversation. Thank you.
Okay, thank you so much, Nick. There was a bit of difficulty with your microphone, so maybe for the next discussion you can look into that. Yeah, okay, that's great. We could understand you, but it was quite hard at sometimes. Then we move on to the next speaker, Katrin from Improva. Can you introduce yourself?
Yes, thank you. My name is Katrien Vinkenauer. I'm a professor of youth studies at Utrecht University in the Netherlands. And I'm also leading our strategic theme called Dynamics of Youth, where researchers from all 7 faculties, including the medical scientists, collaborate to strengthen the resilience and well-being of children, adolescents, and young adults. Our focus on youth and the interdisciplinary teamwork got us involved in Improva. And the Improva project is an international consortium that has 3 main goals. First, we want to strengthen high school students' mental health. We want to improve the detection of mental health problems, and we want to prevent common mental health issues before they start. What makes Improva special is that we didn't develop the tools for Improva not only with scientists, but we work directly with young people, their families, teachers, and policymakers across 4 countries. We asked them, what should Improva look like, the platform, how easy is it to use, does the language fit? This joint co-creation effort ensured that the tools and the information that we developed is relevant to all users and speak their language, something that was mentioned by Prasanna too. Our efforts resulted in the Improva platform, and that's an easy-to-use online space. It offers modules for adolescents and teachers and information for parents. We designed it to decrease the risk of stigma as much as possible. For example, we encourage adolescents to seek help by teaching them about mental health and debunk common myths like only the weak or the crazy have problems. Adolescents can use the platform privately to explore their needs without the fear of judgment by teachers, peers, or parents. And they can pick and choose modules based on what they need most, which hopefully keeps them engaged. Instead of targeting problems directly, the adolescent modules focus on promoting overall well-being. The topics cover real-life stress, such as getting over a breakup, handling social media, or dealing with school pressure. The modules were developed with clinical experts and provide positive support to help teens feel more in charge and in control of their own lives. For teachers, the modules include tools for self-care and self-compassion, and we help them identify and reduce stigma and give them clear ways to talk with students, families, and school services about mental health issues. So, through Improva, we've built a flexible, user-friendly digital platform that makes mental health support in schools practical and accessible to everyone involved in a young person's life, and of course, the adolescents themselves.
Okay, thank you so much, Katrien. We will hear more from you later. Next up is Hannah from Mentbest.
Yeah, thank you. Good morning, everyone. I'm very happy to be here and to join this webinar. I'm Hannah. I'm the Deputy Scientific Director at the German Foundation for Depression and Suicide Prevention, where I work on how digital tools and artificial intelligence can help us to better understand and treat depression. The Mentbest project is a European initiative that focuses on protecting and strengthening mental health during times of major change, things like pandemics, war, or economic crisis. What makes Mentbest special is its strong focus on inclusiveness. The goal is to make sure mental health support reaches everyone, no matter their age, background, or life situation. At the center of the Mentbest project is Mentina, a smart mental health app that helps people manage stress, anxiety, and emotional well-being in their everyday lives. The app is designed to learn from users over time and uses AI responsibly to give personalized tips and early warnings about potential mental health risks. it's designed for everyone, not just those with a diagnosed condition, but also for people who might simply be feeling overwhelmed or burned out. We are currently testing Mentina in Spain, Germany, and Denmark, and we are working closely with people from different communities to make sure it fits a wide range of needs and cultures. Mentina is part of a broader approach that combines digital intervention with local community-based support, because we know that technology works best when it complements real human connection. Mentbest also pays special attention to groups who face more stress or fewer resources, such as young people, migrants, and those who have been unemployed long-term. By breaking down barriers like stigma, language, and access, we want to make prevention and early support more fair and more available to everyone. In the end, Mentbest is about building a more inclusive and responsive mental health system, one that can adapt quickly in times of change and support people wherever they are, especially in times of change. And I'm looking forward very much to the discussion, and thank you for having me.
Okay, thank you, Hannah. Thank you so much. Next up is Esme from my own Reconnected project. Esme, can you tell a bit more about yourself and the project?
Thanks, Annette, and greetings and good morning, everyone. My name is Esme Ducani, and I'm a postgraduate researcher at St Mary's University, which is based in the UK. So it's a great pleasure to be part of this panel and to also represent the Reconnected project. So a bit about my background. So I work in global mental health, but in the past 10 years, I've largely focused on kind of developing, evaluating, and implementing digital interventions. So to introduce the project, Reconnected aims to develop a digital support system to promote resilience and well-being in 9 different vulnerable populations, which broadly includes youth groups, military personnel, older adults, adults with low socioeconomic status, elderly people, and also migrants. So the intervention essentially has 3 components. It includes psychoeducation and destigmatization, so creating more awareness around mental health. Also a core component is resilience, so promoting mental health, self-management skills, even through difficult times, and also social participation. So really kind of encouraging people to engage in their communities and build supportive environments. So in relation to how our project promotes inclusiveness, I would say it does this in 3 ways. First and foremost, and obviously the most kind of obvious one, is that the research is built around reaching vulnerable populations whose mental health is disproportionately impacted by global events such as climate change, war, virus outbreaks such as the pandemic, to list a few examples. Essentially, the project aims to develop a digital solution to bridge support gaps for groups that are typically underserved, excluded, and experience high levels of stigma. I would say another important way in which we do this is our strong commitment to involving the target population. We actually have a work package that's specifically focused on this. So all of the countries have set up advisory committees with end users and topic experts who we consult across key phases of the project to ensure that the intervention is responsive to local and population needs, as opposed to having a one-size-fits-all type intervention. And finally, and very quickly, and I think this point also relates to some of the co-production work that we're doing, but we've been doing quite a lot of work around culturally adapting the intervention. So this really goes beyond kind of just selecting interventions and adapting the language, but ensuring that the interventions feel acceptable, familiar, and meaningful, in different cultural contexts, to ensure that the needs and values of different and local communities are reflected. So I'm sure there are other ways as well, but I think I'll stop there.
Yay. Thank you, Esme. Then we have one more project, the project Smile to Go. And Vincenza, can you introduce your project?
Yes, perfect. I try to start the camera, but maybe the host have to solve this issue. And in this case, we can see my face. And but I started to introduce, yeah, perfect. Okay, it doesn't work. Camera.
Can somebody help Vincenza with the camera, or?
Yes, I click on start my video, but doesn't work. But are you able to hear me?
We cannot see you, Vincenza, but maybe we can otherwise
Yeah, but so
speak without camera.
the camera doesn't work. I don't know why. In any case, good morning, everyone. So I'm excited to introduce the Horizon Smile on behalf of my colleague and project partner. Our e-mental health initiative designed to make support accessible, human-centered, and stigma-free. SMILE stands for Supporting Mental Health in Young People, Integrated Methodology for Clinical Decisions and Evidence-Based Intervention. Our target group are adolescents in the age range from 10 to 24, and the Horizon Smile project is not developing only a single tool, but a digital ecosystem composed of a companion app for everyday self-care, a serious game to promote engagement and skill building, an open knowledge platform for interactive learning, and finally a decision support system to guide the users, healthcare professional, toward appropriate intervention. And together, this component, we want to provide a comprehensive, accessible, and personalized approach to mental health support. I'm a geriatrician, and this is something strange as the target population is adolescent, but the main principle that guide my engagement in this project is regarding the approach in a lifetime, so a lifetime approach to mood disorder that sometimes occur later in life. But what are my opinion and concept on this? Because in the past, coping strategies or talking about mental health was very stigmatized. So SMILE aims to tackle this challenge by monitor the mental well-being and normalizing the topic. So in a human-centered way, amplifying support, guiding users to the right intervention, and fostering a meaningful connection between end users and healthcare professionals, making the access to care proactive. So Horizon Smile represents a vision where mental health support is co-designed, collaborative, and human-centered. And the digital ecosystem is powered by the voices of user and stakeholder. And this is why, beyond the final users, our stakeholder community is at the heart of our project. So, and this is why we engaged over 500 stakeholders across different sectors. And we provide continuous feedback. And to facilitate this open communication, we have created a dedicated online space on our website where community members can interact, participate, share ideas, and contribute directly to the project evolution since the beginning. Today, currently in 7 countries, is starting the recruitment for pilot implementation. Thank you again, and hope to discuss more in the further webinar.
Thank you, Vincenza. We could hear you very well. We hope to see you later on during the discussion. Hopefully your camera will work. So thank you to all the panelists in general. Engaging in these groups in research is fundamental. And we heard lots about youth, which is a focus of much research at the moment, but also from other vulnerable groups. Yeah, and engaging all this group, that's really fundamental for ensuring that the outcome of our strategies are meaningful for the community. Now we will transition to our moderated discussion, and we have posed 4 questions that we will ask some of the panel members. And we encourage an open dialogue among all participants. Let's begin with our first topic, and that is, how is mental health stigma relevant to the vulnerable group in your e-mental health project? Maybe I can give the floor again to Alsbita from ASP-belong. Do you want to start this discussion?
Absolutely, gladly. Yes, so the video should be working. So first of all, as I mentioned before, we're dealing with the group of 12 to 13-year-olds right now in the research phase when we are testing what we have designed. We are expecting that the program will be more broadly applicable to 11 to 14-year-olds. And this is a group where stigma may have actually fatal consequences because developmentally they're in a very sensitive age where the peer relations, as you all know, are absolutely crucial for the well-being of the children or young people. And so the developmental perspective is one that is absolutely key to what we're doing. I believe that it is also a generational thing where the people, as I mentioned before, those young people are familiar with all those labels or diagnoses, as we call them, but they're not trained to deal with them, to understand them, and to understand the stories behind people's behavior. So this is where I think stigma comes to stage and is very, very dangerous and can be a very dangerous basis for bullying and further problems and exclusion, social exclusion of the children. Yeah, I'm thinking if there was anything else, but I would very much love to hear more answers from other panelists and maybe follow up with them.
Yeah, that's great, Alsbeta. Yeah, maybe Esme, do you want to continue talking about this topic?
Yeah, sure. So I suppose with the Reconnected project, we work with several vulnerable populations, and I thought maybe to kind of contextualize this a bit more, I'll focus on non-Western migrants, which is the population group that the UK is currently focused on working with. So very briefly, to kind of just define what non-Western migrants mean and how we define it. This basically includes anyone who's born outside of EU state countries, North America, Australasia, and also is in short-term or long-term residence in the UK. So broadly speaking, mental health stigma remains a major issue in the UK. Recently, a survey showed that around 50% of people reported feeling shame, in relation to experiencing mental health challenges, and often stigma is perceived to be far worse than the symptoms actually being experienced. And I think to compound this, stigma is often a lot more pronounced within non-Western migrants in the UK for multiple reasons. On a cultural level, non-Western migrants often link mental health to perceived personal weakness or, spiritual beliefs, or even fear kind of being labeled mad or incompetent, which are actually, I think, sentiments that also relate to Western countries and stigma as well. And actually, on top of that, it also gets worse in that migrants worry about acknowledging their kind of mental health struggles could affect their legal status and job prospects, especially considering the very negative discourse around migrants in the UK and actually potentially across Europe as well. So essentially, our project aims to address this by kind of framing the program in a way that's kind of empowering and non-clinical, so essentially focusing on well-being and resilience. There's also a very important kind of, I think one of the 3 components that I mentioned are part of the intervention include kind of mental health literacy and destigmatization, which aim to normalize experiences and really kind of build awareness that around mental distress that they might not have had, and actually kind of come to a realization that they could alleviate some of the symptoms that they're experiencing. And then the final point, obviously, being that the digital intervention itself is a great way of enabling marginalized populations who otherwise would not access interventions to access mental health support in a way that they feel secure that it's not going to be registered in the healthcare system and so on. So I think those were my points. I think I probably should stop there because I've gone on for a bit too long, but I'd love to hear what everyone else thinks.
Yeah, that's no problem, Esme. Maybe Vincenza, you can just say a few words about your project. I'm already hearing quite interesting things like that generations might play.
Yeah, absolutely. Also for Horizon Smile. So stigma is very relevant for our target group. If you think, for example, children and adolescents who are in the critical development stage and may lack language or agency to articulate distress that could be escalated in the more challenging issues. And for young adults that are in the transitional phase to independence, often experiencing stress for a job application or maybe for the university career, identity shift and life instability. And if you talk about some subgroup with additional vulnerability, like for example, people with a low socioeconomic status, migrant backgrounds, and rural or remote youth, LGBTQ+, or those with limited digital literacy. Why stigma is highly relevant for our group? I can synthesize in 4 points. The first, stigma as a barrier to early help seeking. And the research consistently shows youth are least likely to seek help from professionals due to fear of judgment and shame or being labeled like mentally ill. And adolescents may internalize in the other way messages like I should be strong, or others will think I'm crazy or I'm not serious enough. So in the SMILE target group, stigma directly leads to underdiagnosis, undertreated symptoms, and especially social isolation. And the second point is the intersectional stigma and compounded vulnerabilities, because this double burden can result in silence, in mistrusting services, and digital disengagement if content feels irrelevant or judgmental. So if YAF facing additional social barrier, experienced layered stigma, both general mental health stigma and stigma linked, for example, to identity or background. And this is why interventions must not only be destigmatizing, but also culturally sensitive and inclusive. The third point is a stigma transferred through adults and system, because teachers, parents, or peers may hold stigmatizing attitude, discouraging open conversation. Even well-intended professionals can medicalize or moralize distress that can reinforce shame. And this is why SMILE enriches this by including educational component for parents, for teachers, for educators, but also for policymakers. And final, regarding to the use of digital tools, in mental health, stigma also influences how youth engage digitally, because they may avoid, for example, apps or digital tools labeled mental health. They prefer, for example, something framing in the name of well-being or life skill. There are another concern regarding the fear of data privacy breaches, or being tracked also feeds stigma-related avoidance. So SMILE would address this kind of problem, use a low threshold, privacy-preserving, youth-friendly digital design. So in our project, stigma is at the core of our intervention to be addressed.
Okay, thank you so much, Vincenza. I think it all becomes very clear that stigma is well addressed in most of these projects, and you thought it well through. There's one question I want to ask you all as panelists from Peggy, actually one of the participants. She thanks you for sharing your insights, and many initiatives target self-stigma and stigma within communities. Well, that's what you also explained. But provider-level stigma, particularly in primary care, can still hinder access to care. As digital interventions increasingly guide people toward healthcare services, how are programs addressing this challenge along with structural barriers, like institutional policies and the burden of patients of having to retell their stories across different levels of care? Did anyone think about that in their project, or does anyone see problems there or can respond to this?
I can address this question. So thank you, Peggy, for providing us your question. Because in our project, the challenges to realize program at the institutional level require the stakeholder involvement at different levels and increase the awareness about the issue. This is not for today, but also for the future. Because if we address the resilience of adolescents, we want to create a more resistant society for the citizen of the future. But it's important for policymakers they have evidence-based to create program. Without evidence, policymakers are not so confident in create or addressing funding for this kind of project. Because we know there are some fear about digital tools. But it's important to create education in how we can use digital to offer the best solution for the problem, which is in this case mental health. So first of all, increase our evidence-based.
Okay. Maybe Elspeth or Esme, do you have anything?
Yeah, I would love to respond. I suspect that Peggy, correct me if I'm wrong, might be referring to clinical population and like retelling the story in various phases of the care, and that's a pure nightmare. And I absolutely share the concern about how uncomfortable and victimifying, is that a word? Like enhancing the victimization of those people, even worse. I thought it's worth mentioning that, for instance, in ASP, we're working with non-clinical population, meaning that we're not excluding clinical population, but we're working with a broader group. And so our task is mainly to normalize talking and thinking about mental health, so that it might be in the future, it might be less uncomfortable for people to talk about that at all. And but I want to mention some structural barriers that we have run into. And one is on the level of schools and teachers. So when we started the project, I had a first consult with an expert co-researcher we've had involved. And they said, well, your biggest challenge will be to persuade teachers that mental health is something they should be dealing with at all. And so, for instance, here in the Czech Republic, we're really doing our best to bring the topic to schools, to regular teachers who are focusing on maths or Czech or literature or English, and telling them, well-being is a part of it. And if the children are not well, they won't learn maths or Czech or English. And this is a very basic structural barrier that we're facing and trying to overcome. I think that through building relationship of trust with the school, slowly in a long term, gaining their trust, giving them tools they can work with that are not demanding. We're not adding the burden to the system, to the people working in the system, because they have a lot of obligations to fill in. I think we're slowly getting there, to getting them on board of acknowledging the topic of mental health in schools, for instance. And the second example, and I don't want to be too long, so I'll try to be brief. We've run into schools that are very specific, for instance, extremely socially disadvantaged. They're, inclusive schools in areas that are all socially disadvantaged, and they often face rejection from programs that are offered to normal schools, with some sort of regular level of disadvantagement or special needs. And I'm very, very curious about how we succeeded in designing something inclusive to be applicable in all these kinds of environments that are there.
Yeah, thank you so much for those insights. I think that really is a nice bridge also to the next question that we pose. And for the next question, I want to invite Elzbieta again, so you can stay for this question and maybe elaborate a bit more on this question. And Hannah, Prasansa, and Nick are also joining this discussion. And an important question, because I think we all try really hard, but can e-inclusion, so inclusion through digital technologies, really help to decrease the problems associated with mental health stigma within our vulnerable populations? And how? And maybe to give you a bit of a break, Elzbieta, Hannah can start with this question.
Yeah, thank you very much. I'm happy to start. Yeah, like in short, I would say yes, like e-inclusion can help to reduce mental health stigma in vulnerable groups. And part of my response is built on a recent analysis that we've done and published about the implementation of a digital intervention for depression in Arabic-speaking populations in Germany. And our analysis showed that culturally and linguistically tailored digital tools, like an app designed for Arabic-speaking migrants, made mental health support more accessible and acceptable to these populations. So I think digital tools offer privacy and anonymity, which may lower fear of judgment and encourage people to seek help. Digital interventions can also help to overcome practical barriers such as distance or limited access to professionals. But on the other hand, our study has also highlighted a key challenge, that adoption was limited. So this means that in our study, fewer Arabic-speaking users signed up for the intervention after being invited, compared to the German-speaking users. So the German-speaking users went through to a much higher rate from the invitation to using the app, whilst we invited Arabic-speaking users, but they just didn't go through with it. They were like, oh yeah, accepted the invitation, but they never acted on it or used the app. So that showed that even a well-designed tool needs more strategies to support users and to boost the engagement and uptake of the intervention. So I think e-inclusion provides access and reduces stigma because it provides support that is private and culturally relevant and easy to reach. But we also need to keep in mind that we really have to care in depth that people can also adopt and use the intervention, and that there may be other hurdles that need addressing for these groups. So we need to don't take it too easily and just throw out e-interventions to these vulnerable groups and think we've done everything. I think we need to really care that it reaches the people. Yeah. And if you don't mind, I would share the manuscript in just the link in the chat. That's okay. If someone wants to follow up.
Sorry, you put the link in the chat. And Hannah, I was just thinking, do you have any ideas about what we should or what we can do or what strategies we can use to increase adoption of these interventions? This is probably the hard part.
Yeah, I've become a big fan of the Think Aloud approach. We're using that in another EU-funded project at the moment, where we make a first kind of version of the intervention, and then we sit down with people of the target group and said, okay, now you've been invited, start using it and just talk about what you think, like openly. And then it's a qualitative approach, so then kind of transcribe all of it. It's a lot of work, but then I feel like we get a lot of insights that things that we had not thought about. People say like, oh yeah, but this just looks ugly. I don't want to click on it. And we're like, oh, so it's so simple things sometimes. Oh, it's very like side comments that they make in this think aloud approach. And I think we really need to care to keep working with the co-development of the intervention and not just saying, oh, we designed this and now out to the world, but to keep in touch with people of the target group to constantly improve the intervention and to see what needs to be done to make it user-friendly.
Yeah, that's a great addition. I wanted to give the floor to Prasansa. Can you say something from the perspective of Advance about the topic?
Yeah, so echoing our other panelists, we here at Advance also believe digital interventions to hold a promise to address stigma to some extent by offering a safety net. So meaning a safe space where people can engage in mental health support privately and also without fear of being judged. It's more personal, flexible, and more accessible, as others have also mentioned. So I would also like to give you an example of digital interventions that we are currently testing with adolescents in two of our sites, Germany and Lithuania. So across both countries, our interventions share a common structure. So they combine self-paced digital learning with weekly catch-up sessions that bring a human touch to the process. So this blend helps balance flexibility and connection, which has been key in reducing stigma and keeping participants engaged. So, well, the main difference lies between these interventions across two sites is how the human element is being delivered. So in Lithuania, the program is entirely individual focused. Participants learn at their own pace and have weekly check-ins over the phone with trained e-helpers. Whereas in Germany, the same model is adapted into digital group sessions led by facilitators trained in mental health. So each approach works in its own way. In Germany, where the focus is on climate change distress, these digital group sessions created a safe and supportive space for climate change activists who often feel pressure to appear strong. So sharing their experiences with others facing similar emotions helped normalize distress and reduce the fear of judgment. In Lithuania, young people valued the anonymity and flexibility of chat-based support and the phone calls with the e-helpers. So in both the cases, they could reach out from a safe space that they felt, the safe space and in their own time. So while the format differs, both interventions show that digital tools, when combined with some level of human connection, it can create a powerful sense of safety, reduce stigma, and make mental health support more approachable.
Thank you, Prasansa. Alsbeta, do you want to respond to that?
Yeah, absolutely. Thank you. I absolutely agree with everything Prasansa and Hannah have said. And I would like to follow up on Hannah's mention of co-development because in our program we call Lena, we have involved the target group of those young teenagers in the entire design process. And it was an extremely beneficial thing to do for them and for us. I think we've actually, it was the very, initial phase of the project when we just started thinking about what to do, how to do that. And those young people who joined us for those creative workshops, designing the e-intervention were just amazing, and they shared so much and they brought so much insight into the design process, and they helped us design something that speaks their language. The technology itself, I believe, is a native language. It's a mother tongue of young people today, and we're all aware of the anonymity that might encourage them to share things, and the little bit of distance or safe space that the virtual elements provide. But I think it's very important to speak their language even in the content of the apps. So that has proved extremely, and I think we've learned a lot about our target group through that process. That's probably the most important thing I wanted to mention. And yeah, I would probably park it there.
Okay, that's great, Elzbieta. I think you'll kind of all agree really that involving kind of users, end users, and experts in the process is really important. Nick?
Annette, yeah,
Yeah.
I'm sorry. I'm sorry, Nick. I just wanted to add one more thing that I thought we should probably mention, that the technology might create barriers as well. We need to be aware of that. And I think we'll touch that later. But one group that I thought of only later on the project, when we might create barriers to deal with the topic, are the teachers, for instance, in our cases. So we've been very much focused on the young people and how they're feeling in the game. And we thought, okay, well, designing something that the teacher will do with them, and it must be very user-friendly for the teacher to feel comfortable. But we, right now, in the practice, when we're implementing the thing, we are spending a lot of time taking care of the teacher's needs. So we must always think of all the groups involved. That's just one thing I wanted to mention. Thank you.
Yeah, no, it is a great addition, because we're also asking them to touch upon very difficult topics, and they may feel uncomfortable with it. Yeah, that's true. Okay, Nick, then do you want to?
Yeah, let's check my audio is working okay. Is that a bit better? Happy days.
Yeah.
Yeah, so it's a great question, and I'm going to be a bit controversial. No, I don't think inclusion can help the decreased problems associated with mental health stigma. I think young people we work with are very aware that they're working on a mental health app, and whilst this increases the potential for access and involvement to get advice and support on a tool anonymously, that doesn't remove stigma. So if they could secretly be on their phone using a mental health app because they're still ashamed, and the stigma is still there about telling their friends and talking to anyone. So I think it definitely increases accessibility, but I still think the stigma needs to be cracking a bit in order for young people to actually engage with the process in the first place. Again, this is young people that we speak to, our youth advisory board for the Bootstrap project, or the Boot Crew as they're known. Shout out. They'll openly talk, but they'll openly talk about their mental health, and fortunately for them, they were able to get the confidence to seek help in the first place. And I do think that inclusion will enable young people to get support, but it's still, as far as I'm concerned, that doesn't remove stigma. The stigma's still there if they're ashamed of getting that support and unable to talk to anyone about it. I did some work with some young people who were 15 from Croatia before, and they were telling in a school, and they were telling us that they haven't told their parents because they're ashamed of, they were in a mental health group at school, but they hadn't told their parents because they were worried about what their parents said. And of course, parents, have access to lots of teenagers' phones and their internet use as well. In theory, I know that's not the case for a lot of teenagers, so that as well is an extra barrier, so they're not going to download a mental health app because they're worried that their parents or someone might see it and ask them, why have you put this on your phone? Is everything okay? I do think, going back to co-production, I think that's a really good way of engaging and breaking stigma in creating these tools. And something that the Bootstrap project is creating apps with a specific problem, problematic use of the internet. So rather than it being about mental health, it's kind of like, do you think you're using the mental health too much for your life? Are you doom scrolling for too long? And maybe it's causing you to be, and maybe it is causing you to be anxious. Then let's have a look at this. We'll, assess it and then get some support about that particular thing, as opposed to mental health as a broad concept. And our entire work is obviously based on the impact that young people's constant access to the digital world actually harms their mental health. The World Health Organization released a study, teen screens and mental health last year, again, with the link of digital engagement, especially social media, and then mental health. And I do worry sometimes as a youth worker that young people are being bombarded by digital technology now. So I do think there's a balance, and I think, I can't remember exactly who, but someone else talked about the idea of having elements of digital autonomy, being able to do something online, and that does increase inclusion, especially for those maybe unable to reach therapeutics, physical spaces. Their geography might inhibit them being able to reach a clinic or something. But at the same time, there needs to be a kind of gentle balance in addressing that. And so a face-to-face relationships do need to happen as well. Because obviously on the flip side, if you're living in maybe a rural area where the internet signal's rubbish, that actually excludes you if everything moves on to an online platform. I'm not saying everything's going to move online. And so I think I do believe that it's a very fine line. I don't think it'll do a little bit for removing stigma, but it'll primarily, I think, help increase access. But the stigma, I think, sadly, might still be there unless, young people themselves can convince friends to go on this app and learn about mental health as well and be made more aware. I'll stop there and welcome to answer any other questions and carry on from that.
Yeah, thank you, Nick. I basically have a question for you, but I also want the other panel members maybe to respond very quickly. I don't know if anyone wants to respond.
Yeah, just wanted to add, especially with regards to internalized stigma, I guess, as you said, Nick, perhaps the stigma within ourselves may be hesitant, like some youth might be hesitant to engage in intervention overall. But I guess although we won't be able to remove stigma completely, but then there are maybe some ways to go about it, as we have said earlier about the use of languages, how we frame the intervention as a whole. So rather framing our intervention to promote well-being, to manage their emotions, for emotions regulation, for example, or maybe bringing in the creative approaches to our intervention. So not making it a very boring psychoeducation format, but then bringing in the gamification process. I think those are the ways we might be able to address to some extent, but then removing it completely, that's a huge challenge for all of us. So yeah, just wanted to add those.
Yeah, thank you. Basically, it would also answer I would want to ask Nick about what he thinks is needed to reduce stigma, but you basically already gave some suggestions.
Happy to, I think what Prasansa was saying then about language is really, really important. The Boostrap project works across 9 sites across 9 different countries, and we hold these amazing boot camps where we get young people sort of 12 to 16 from all these countries come to one place for 3 days to do lots of co-creative and co-production work. And obviously it's all done in English, but we try our best to engage in various different languages. There's teachers there to help. And language is so important. So we're doing all, and most of us are probably all doing research in English, right? And there's certain words in different countries that don't exist in English, and vice versa, for one. But also, even like you mentioned, Prasansa, the youth language. What language are young people using in terms of how they're talking about their emotions and their mental health and struggling, but also cultural language. I think Elspeth, you've mentioned about cultural and kind of different communities' language and how Black communities talk about mental health and how LGBTQ address mental health. Thinking about all these different things as well comes into it, and that's a whole other conversation about inclusion, because I'm very aware that when we do co-production work as an organization, Eurojouth Mental Health, and our boot camps, the majority of the group is white European. And I think in the previous question, someone mentioned about migrants, or Hannah might be, talked about migrants and refugees, and that's another community of young people that need slightly different approaches. But I guess it's a first step, these research projects, right? It's like, okay, well, if this is working, how can we then make it more, adapt it to help specific communities or vulnerable groups, as we've been talking about today.
Yeah, thank you, Nick. I'm mindful of time, so we move on to the next question, and therefore I want to invite Nick again, so you can kind of stay, and Vicenza and Catherine. And the question we're posing here is that, well, we have low threshold, and I think we will follow the discussion. Low threshold of accessing e-interventions and normalizing symptoms of mental health may both be strategies to overcome stigma. I think we heard that before. Is this something that happens in your project, and what may be the benefits and also the risks of that, of normalizing symptoms and of accessing e-interventions? I don't know. Catherine, do you want to start? Maybe?
Thank you. Yes, of course, I would love to start. I tried to be brief because a lot of things have already been mentioned, like accessibility. You can scale it so you reach more people. It's possible to have an early prevention potentially, so support subclinical people. Things can be tailored, so that's an advantage. And in our case, we involve the teachers and the parents and the school personnel, so that can help in talking about mental health in the school setting. So it becomes more of a culture of talking about problems. So not everybody can succeed. However, when you look at the literature, you see that it's still the rich are getting richer. And so those with higher socioeconomic background profit more from general interventions. There is very limited evidence, like good evidence for the effectiveness of interventions. People may drop off. So what we saw is that adolescents may start a module, but then they think, that's too much work. I'll ask ChatGPT. That's easier and much more nice to me. And some people may over-rely. And I wanted to react to Nick's observation that anything that you do online needs to be translated to real life, real relationships, real people. And many of the interventions, and some people call it face the valley of death. So that there is an enormous gap between what you see online and you feel comfortable, but then you have to actually talk to a peer or a parent or somebody who's totally the opposite of who you are, and then it doesn't work. But I learned it all online. So the proof is in the pudding, I think, in eating the pudding. So yeah. So what we also were wondering is whether it would be useful to ask adolescents, for example, if they have at least one person to confide in, one person that they can really be themselves, who accepts them in their daily life. So not only the online, and I have to see, because yeah, it was mentioned already by Prasanna, that ideally you mix the online and an offline intervention. So
yeah, basically what you're also saying, it could be a risk if you isolate yourself with the online world.
yeah. I don't know whether you want me to talk about iatrogenic effect, so that things backfire. We can try as much as we want, but once you implement things, you can have the opposite effect despite all good intentions. And there are, like, people may misinterpret symptoms, so think they have something, but they don't. You can increase anxiety and distress just by perhaps, or especially in adolescence, you can also see, oh, some people who have a problem get more attention by others. So perhaps I should have a problem too because I want attention. But it can also feel super lonely and isolate people because, you feel that you can be there online, but you cannot do it in real life, which may even make people feel more lonely than they were before.
Yeah, it's good, really good to think about these things as well, because we all have
Nick talked about it already.
already. Yeah, that's true. Maybe Vincenza, do you want to say something first?
Absolutely, because both these strategies are very central for our project, because by providing a low threshold digital platform, young people can access self-assessment, monitoring tools, and gamified intervention that are the features that are useful to use during their period, and in the what fashion privately and without barriers, which help reduce the fear of judgment or encourage them to an early engagement. So, by avoiding clinical labels like treatment or disorder, young people feel more comfortable engaging with this kind of tools. And regarding the self-improvement, wellness, rather than a mental illness apps. It's important the language, as Nick before said, that could increase the reach and uptake of this kind of tools. And the low threshold entry allow early access before symptoms escalate to clinical levels. So the empowerment and the self-efficacy of this kind of strategies that normalizing everyday distress help users see mental health as a part of general well-being. It's not something to be hidden. So it is encourage the self-management and agency. So people say that it's okay to feel in this way. I can do something about it. So take awareness about the importance of their mind, the message that their mind could give people. So, and it's important to stop and in your private room in the morning, in the afternoon, or maybe in the night, because adolescents stay awake also in the night when they have some troubles, and they have something in your hands, but good instrument that is validated by project, and so the feedback of stakeholders is very important. It's not just a tool that adolescents use in an improper way, because this tool is co-created with teacher, parent, healthcare professional. So this is the right guide. But it's important to mention also the risk. So normalize the mental issues have the risk of trivializing serious symptoms, because over-normalization may blur the line between common stress and clinical depression, clinical anxiety that is worth to be treated. So users may delay seeking professional help because they assume it's normal or that by myself I can manage. And to mitigate this risk, I can suggest to include the clear escalation prompts in your digital tools and integrated referral pathway when this alarm or alert could be active. So another risk I can mention is mismatched expectation, because users may expect full treatment but only receive psychoeducation or cognitive behavioral therapy for light or moderate anxiety or depression. And this can cause disappointment and disengagement. So the mitigation of this risk could be communicate clearly the scope and limits of the intervention in a transparently way at onboarding. And so the last point I want to highlight is the potential medicalization backlash. So when we normalize this problem, these issues, yes, it can reduce stigma, but also encourage over-identification with mental health labels. So everyone is anxious. So I have a disorder? No. So we need to emphasize the spectrum thinking and resilience building, not pathologizing. So just to create a framework where mental health is something the people have to take care without thinking about pathologies. This is so just some thinking.
Thank you. Yeah, we have a fourth question, and I want to spend a few minutes on that. Nick, do you have a very quick response to this?
Yes, I can give a very quick response. I agree with what both are saying. I think the Bootstrap project we have, looking at what we have a low threshold access of the intervention. But that's, I guess, what I was thinking there is because it's about problematic use of the internet. Mental health and well-being is an undertone of it, but it's like reaching out about a specific problem. So, and I think that has an element. But as Vincenza just said, I think my concern and risk about it is trivializing serious conditions. I always used to, when trying to debunk stigma in the UK, talk about the analogy of when you break a leg, you go see a doctor. So it's like when your brain snaps, you might go see a doctor because your depression's impacting you so much, but you wouldn't go on an app to get your broken leg fixed. So it's having those levels of what are these apps for, and it could be something really positive about the interventions being a helpful gap filler of preventative work, because that's something at least in the UK and lots of other countries I've worked in, have often struggled with. They're often very reactive to mental health problems and crises, and so preventative work could be a really good way of helping people look after themselves.
Okay, thank you, Nick. Then we have one final question, and maybe we can kind of have very kind of brief answers, but it's an interesting topic, and I want to invite Esme for that. Catherine is already kind of here. Hannah and Prasansa. So in theory, e-interventions are easily accessible. We talked a lot about it, and they have the potential to reach many people, but in practice, this is not usually the case. I think that came up before, also with Hannah, that you try to reach as many as possible. But is it really possible to be really inclusive that these interventions are, or is that just one bridge too far, and should we try as many as possible? Maybe Esme, you want to start with a brief remark?
Yeah, sure. So I think this is a really important question. I'm really glad that you raised it. I think to kind of mirror sentiments mentioned before, digital technologies hold a tremendous kind of promise in terms of like increasing access and reach. But at the same time, a lot of the communities that would most benefit from digital technologies, and I think this is specifically relevant to our project, often are affected by what we call the digital divide, which is inequalities in relation to kind of connecting to the internet and accessing digital tools and actually being able to use those tools. So just thinking about migrant groups, for example, we know that they are impacted by the digital exclusion. So they tend to have unstable internets, they rely on shared Wi-Fi, they have low quality devices. Often they're also required to kind of show appropriate IDs to access online kind of NHS portals, healthcare portals, which, presents a huge barrier. And I think in addition to this, even if once they have the kind of available device or connection, there are also issues around language barriers and also being able to use or effectively navigate through different types of like applications or digital platforms, which can be quite overwhelming. So I know I don't have a lot of time, but in summary, while I think these kind of challenges seem insurmountable, I do think there are solutions. There are kind of public level interventions, such as, increasing access to free internet, rolling out literacy programs, even employing digital navigators at, appropriate kind of services, whether it's within NHS or NGOs, in which there are people who can help people use and access digital innovations. And one last thing that I did want to mention as well, I think while access is really important, I think that's not the only issue. I think engagement is also critical. And I think this has been mentioned before about needing human contact. And this is specifically important for our population group who tend to come from kind of collectivist communities, who value social contact. So I do think our kind of cultural adaptation and how we think about access shouldn't kind of be limited to people accessing a digital platform, but actually the method in which they receive treatment should be a lot more holistic and should also provide opportunities for people to access human contact as well. But I think I'll stop there.
Okay, thank you, Esme. Catherine, do you want to add anything to that?
Yeah, I can only echo what Esme just said, to be honest. And because, the other thing, my response to the question would be, although I'm a firm believer in ensuring access to mental health care, I don't think that e-interventions are the solution. Partially exactly what Nick just says in the app, in the chat. Relationships are still the basis of everything. And to me, in general, I mean, in the PISA research, for example, you see that parents who ask children, how are you doing, are the best predictor of life satisfaction in adolescence. So parent-child relationships, a hug or a touch will be quite important, independent of all the promises of online interventions. So that's it.
Hannah, do you?
Yeah, I think I couldn't agree more with what you just said, Catherine. I think that's the core is still the personal relationship, and you cannot just digitalize everything, because then you run into the new big challenges, which are also then having to be addressed, like loneliness, social disconnect. So I think it always needs to go in conjunct with the human the human connection. But just I wanted to follow up on what Asma said, because I think it's a very important point. If we do the digital interventions, and I think we should do them, it's a good tool. The digital divide doesn't only affect migrants, but only such as Beta said earlier, teachers, other people that are older and have not grown up with these tools, who are afraid of having their data taken to the cloud, and they don't know what's happening with their personal information. So I think in Germany there's a lot of worry about protection of personal data, and you cook thousands of cookie agree things, and you just don't understand where it goes. And I think that's only going to be exacerbated in times of AI. So it's really important to explain what is happening with my data. That's where explainable AI comes in, like what is really happening in these models and how is output going to be generated, what does it actually mean? I think there are big challenges to make it really workable for everyone and to ensure inclusiveness and access. And I think I'll stop there. I could go on more, but I think these are my main points.
Yeah, it's a topic that you can talk about for a long time. Maybe Prasansa, do you want to have a final word?
Yeah, I also want to reiterate that access doesn't automatically mean inclusion, and there are so many equity factors that come into play, and the structural barriers that can really prevent us from reaching out to the people that need the intervention the most. So I just want to focus that we as a mental health researchers or interventionists to apply this equity and human-centered lens in our work. So also going beyond to ask the questions on who is being left out and why, rethinking strategies on how we can really make our interventions, our research, to really bring in those people on board. Requires a lot of rethinking and requires a lot of work, but I think that's very much necessary in order to be inclusive in our design.
Yeah, thank you so much, Prasansa. It's actually, we have 1 minute to go, so I have to round off. I think people have to go to other meetings. There has been a lively Q&A already. I saw like a lot of responses from panel members and to the questions of the people who were listening. So I hope that was sufficient for you. All panelists, thank you so much for all your thoughtful questions, contributions. Also I think we agree a lot that there are downsides and also about the topic. And there's just a lot to say about this topic. Yeah, to round up, it's our 5th webinar in the mental health dialogue series that we jointly organized, and I think they are getting more and more lively, which is really good news. For the people kind of at home or at work, be sure to register for the next sessions if you like this and continue the important conversations. The webinar series will run every 4 months, so the next one will be in a couple of months. And you can find the registration link in the chat if you want to. And I encourage participants to pre-register using the QR code or the link in the chat. Also, I'd like to encourage everyone to visit the websites of the 7 sister projects. I think we're all nearly halfway, so there are a lot of exciting things going on in all these projects. So it's really a nice time to follow everyone, and first outcomes will follow soon. That's very, very exciting. And you can see all the chats, all the websites in the link. So thank you once again to all the speakers and all the participants, and we look forward to seeing you at our future webinars. And have a great day. And I'm just 1 minute over time, so that's excellent. Thanks so much.
Thank you.
Thank you.
Thanks, guys. Have a great day.
Thank you, everyone. Bye.
Thank you, everyone. Bye.